Okay, thank you, Dr. Zhang. We have the second speaker, Professor Hsin-Yang. He graduated from the National Yu-Ming University and also got a PhD degree in the Yu-Ming University. Previously, he was the director of the infertility department of Veteran General Hospital in Taipei. And he also the former president of the Fertility Society, ROC. Currently, he was in Yu-Ming Fertility Center. And please, Dr.
Thanks, Professor Hu, for your kind introduction. Ladies and gentlemen, it's my great honor to be invited by the organizing committee. The topic I'm going to talk about is, let's be honest with our patients about PGT-A. PGT-A is the abbreviation of pre-implantation genetic testing for an employee. Why I choose this topic? Because more and more patients undergoing IVF ask for PGT-A. Does it really help our patients? First, I will introduce the background of PGT-A and describe the results of a most recent largest RCT trial, the STAR trial, in its clinical implications. And then I will report the reproductive outcomes of transfer of PGT-A diagnosed mosaic embryos. Finally, I will discuss the rate of chromosomal concordance between trophectoderm biopsy and the inner cell mass. PGT-A was first developed on phase 3 embryos. 1 or 2 cells were taken for fish analysis. And then PGT-A 2.0 was developed on blastocysts. 5 to 10 trophoblast cells were biopsied, followed by DNA analysis. And in 1990s, the PGT-A 1.0 became widespread and to improve IVF outcome. However, results from several RCT trials show that PGT-A 1.0 did not increase live birth rate, and in some cases even reduce live birth rate. So PGT-A 2.0 was developed by doing trophectoderm biopsy and assessment of all chromosome pairs since 2008. And now the most popular DNA analysis is NGS. And firstly, PGT-A has been found to improve ongoing pregnancy rate and decrease miscarriage rate in many cohort studies, but not confirmed by RCT. And PGT-A can decrease multiple pregnancy rate by transferring single euploid blastocysts. It is not associated with adverse outcomes on neurological, cognitive, and anthropoetics of childhood development. Looks like PGT-A has a bright future. However, the most recent study published at the end of 2019, the largest RCT trial, the STAR trial, give PGT-A a big stamp. Now I would like to introduce the largest RCT trial, the STAR trial. The STAR trial is by far the largest RCT trial on PGT-A. It is a large, multi-center and multi-nation RCT trial. And the study was conducted between October 2014 to October 2016 in 34 clinics and 9 genetic labs in the United States, Canada, and United Kingdom and Australia. Females aged between 25 and 40 with at least 2 good quality blastocysts by day 6 were recruited. In the control group, the blastocyst with the most favorable morphology was cryopreserved, and followed by frozen embryo transfer with this single blastocyst. And in the study group, PGT-A was performed on all good blastocysts, and APT was performed with the single euploid blastocyst with the most favorable morphology. So control group is based on morphology only, and the study group is based on euploid chromosome status plus morphology. As you can see, the aneuploid rate is so high. It's about 50% in the young group and about 60% in the old group. So the PGT-A group is expected to beat the control group in ongoing pregnancy rate per ET. Unexpectedly, the results show that the ongoing pregnancy per embryo transfer, there is no difference between the PGT-A and the morphology group. Only in the old age group, women between age between 35 to 40 years old, the PGT-A group has a higher ongoing pregnancy rate per ET as compared with the morphology group. It's about 51% versus 37%. Importantly, there is no difference in biochemical pregnancy rates and miscarriage rate in PGT-A and the morphology groups. Furthermore, the ongoing pregnancy rate per intention to treat, there is no difference between the two groups among all age groups. Richard Paulson has calculated the loss of implantations according to the result of the STAR trial. He calculated that the expected PGT-A implantation rate is control implantation rate over 1 minus aneuploidy rate. And the loss of implantation rate is 1 minus actual PGT-A implantation rate over expected PGT-A implantation rate. According to this equation, the losses of implantation is about 52.8% in the young age group. And it is about, the loss of implantation is about 48% in the old age group. For example, a younger patient with 4 processes in the control group can have 4 single embryo transfer with a control implantation rate of 53%, about 50%. And she can have birth of 2 children. But if this patient underwent PGT-A, she has 4 processes, underwent PGT-A, and she will probably discard 2 of her processes since the aneuploidy rate is about 50%. So she can only have 2 single embryo transfer. With PGT-A implantation rate of about 50%, she can only have 1 child being born. So by doing PGT-A, you may lose 1 baby. The possible causes of PGT-A induced loss of implantations is false positive testing and discarding healthy blood cells and trauma of trophectoderm biopsy. In another paper, by using the mathematical model, it shows that the embryo wastage rate is about 39%. Now I would like to introduce the reproductive outcomes of transfer of PGT-A diagnosed mosaic embryos. In case of meiotic errors, all cells in the embryos will be abnormal, chromosomally abnormal. But if mitotic errors happens, some but not all cells of the embryos will become chromosomally abnormal, resulting in mosaic embryos. PGT-A has some inaccuracies in some aspects. First, only 5 to 9 cells were taken by trophectoderm biopsy and lacked representative of about 200 cells in the blood cells. And mitotic aneuploidies tend to be clonal, like this. So if you unfortunately take these cells for analysis, we will discard this chromosomally normal euploid embryos. And mathematical modeling showed that even under even distribution of aneuploidy cells, more than 25 cells are needed to be biopsied to avoid false positive and false negative results. And in humans and in mice, the ability to self-correct is higher in inner cell mass than in trophectoden. So sometimes the embryo can correct by itself. According to the literature, in PGT-A, by doing PGT-A, about 5 to 15% of the tested embryos are mosaic. But it does not reflect the real conditions. In this paper published in Nature Medicine, all single blastocyst mirrors of the phase 3 embryos were analyzed for chromosomes. And in these 23 embryos, 9% were normal diploid and 8 were mosaic. So the mosaic rate is about 35%. And in our current classification, that less than 20% abnormal cells are reported as normal. More than 80% abnormal cells as aneuploidy, and 20 to 80% as mosaic. It has no scientific and biological basis. And Greco in 2015 first published that he transferred 18 mosaic blastocysts and results in 6 pregnancies, leading to the birth of 6 healthy babies. So the mosaic embryo transfer, the implantation rate is about 33%. In 2019, Victor reported that in embryos with mosaicism, the implantation rate is about 30%, which is a little bit lower than that of the euploidy embryos. And the percentage of abnormal cells in the biopsy has no relation to the implantation rate. So embryos with high mosaicism or low mosaicism, the implantation rate is almost the same. Finally, I will discuss the chromosome concordance between trophectoden and inner cell mass. In this paper, 34 untested embryos were donated for research, and 24 PGT-A diagnosed abnormal embryos were also donated for research. The inner cell mass was isolated, and the trophectoden was further segregated into 3 portions. The results show that there are about 56% of complete concordance, and the mosaic rate is about 44%. And in this part of embryos, the PGT-A carries risk of false positive. As you can see, if you take these red cell abnormal cells, you will think that this embryo is abnormal and discard these embryos. And if the embryo distribution, the abnormal cell distribution is like these 3, the PGT-A carry risk of false negative. Since the embryos may be abnormal, and then you may take the normal cells. And for all the embryos, about 62 will be processed correctly. Notably, of the PGT-A diagnosed mosaic embryos discarded and donated for research, about 31% have euploid profile in the inner cell mass and all trophectoden biopsies. So don't discard mosaic embryos. And in this paper, Glacier reported that of the 11 embryos diagnosed as aneuploidy and donated for research, 4 were chromosomally normal. The inner cell mass were probably normal, and 3 were mosaic, and only two showed exactly the same results. So probably we can count out PGT-A for only sex determination. Not really. Even sex determination can be accurate. As you can see in these 3 embryos, the original diagnosis is XY. This is repeat biopsy is XX. The original is they are XY XX. There are XY XX. So sex determination has also to be careful. And in this paper about 11 processes classified as uniform mosaic, uniform aneuploid, uniform and aneuploid. 93 were uniform whole chromosome aneuploid, and 7 were uniform segmental aneuploid and donated for research. And the inner cells mass was biopsy and followed by another trophectoderm biopsy. The results show that if the biopsy results as uniform whole chromosome aneuploid, the trophectoderm inner cell mass concordance rate is about 95 to 100%, which is very high. So we can count a PGT-A for uniform whole chromosome aneuploid. However, for cases if the biopsy results show that it is segmental aneuploidy, the concordance rate is very low. It's only about 43%. This is supported by a recent paper published by Richard Scott, and he demonstrated that if you transfer the embryo with uniform whole chromosome aneuploidy, the sustained implantation after 13 weeks is 0. So in conclusion, loss of implantation by PGT-A were as high as 40 to 50% and caused by trauma of biopsy or false positive testing. And transfer of PGT-A diagnosed mosaic embryos can lead to ongoing implantation rate of 30 to 45%. And aneuploid cell percentage in trophectoderm biopsies did not correlate with the outcomes. And if high rate of concordance was found if the biopsy showed the result is uniform whole chromosome aneuploid. But if the result is segmental aneuploid or mosaic, the concordance rate between trophectoderm and inner cell mass is low. In the present imperfect state of PGT-A, it's used to be limited to certain clinical situations, like older women with many blood cysts, and its widespread use should be avoided. And non-invasive methods of PGT-A, as well as better understanding of pre-implantation embryo genetics, may help improve PGT-A for more clinical applications. Let's wait for PGT-A 3.0. Thank you very much.